And I'm going to be talking about the temporary effect of the pneumatic retinopexy and the improvements we get in the service provision in the retinal department. There are two parts to my talk. The first part, I'll be talking about the pneumatic retinopexy. The second one, in our local settings, did it help us improving the clinical service or not? And I'm lucky I've got two professors from my department, so it will be a good discussion as well. So pneumatic retinopexy, it's a minimally invasive, very nice procedure which we can easily do in the clinics. What we do is basically inject the gas bubble followed by the laser or the cryopexy. And this procedure has been there since 1911. Different people have done different techniques. There was a trial comparing the PNR versus the scleral buckle done in 1996. The anatomical success rate was slightly low in the pneumatic retinopexy group, but it wasn't significant. But the main study, which changed the trend of the pneumatic retinopexy, was the PIVOT study. What they did in this study was they compared the outcomes in both groups, where they treated the detachment with the pneumatic retinopexy, and the other group was the primary PPV. So coming to the outcomes, the first outcome, the ETDRS visual acuity was much better from first month up to the follow-up of 12 months in the pneumatic group. The primary anatomical success rate was very slightly high in the primary PPV group. That was 93% as compared to the 81% in the pneumatic group. But on the other hand, the pneumatic group had a better outcome in terms of the metamorphopsia, and majority of the patient in the PPV group, they required another surgery, which was the cataract surgery. Now coming to our local settings, these are just the numbers. I think on the average, in our clinic, we see almost about 100 to 200 cases in our retinal department. And on an average, we are doing about 10 to 15 different procedures for the retinal detachment. And because of the workload, we do sometimes struggle with the accommodating patients, especially the MAC-on detachment or the patient who are MAC-off but recently MAC-off. So the question is what to do. There are two options. Either we increase the capacity by having the new machines, more doctors, and more staff, or can we apply the PIVOT study and see if that helps in the clinical provision. So what we did was we used the inclusion criteria which was used in the pneumatic study, and the aim was not to treat, but to buy the time. So if somebody is getting the theater time in 1 week or 2 weeks, what we were trying to do was inject and see if we are able to treat successfully the retinal detachment. If not, then at least they're having a longer time of having a pneumatic retinal attachment, and to see if we can prevent the PVRC. And obviously, if we are operating earlier and not operating in the PVRC group patient, the visual outcome is much better. So in last 8 months, I've done about 23 patients. 16 patients, only 68% had the anatomical success. While in the PIVOT study, it was 82% in the pneumatic. And there is a list of long reasons why they were much lower success rate. But before coming to the causes of the failure, I think we should, if we look on the other side, we were saving a lot of cost in about 68% patient. And if we are doing about 10 to 15 patients a day, we are saving 1 whole day of theater time by just doing the pneumatic retinopexy. And the cases which I did, it was the case mix, single break, multiple breaks, 1 case of dialysis as well. Had a pressure issues, but successfully treated. There was a case of a failed buckle as well. So I'm going to go through the cases. The first case, if you see the right eye, there was a supratemporal break, fresh detachment, 4-wheel bisecting. Came in, had the date for the retinal detachment vitrectomy. while he was waiting for the date, I did the injection of SF6. And interestingly, the results are pretty good. Within 24 hours, the retina dries up. And if you see the third picture on the right side, I've done the laser and it's holding very well. Second case, supranasally, there was a single break and macula still on. I injected the SF6, later on did the laser, and still holding very well. Third case, again a single break retinal detachment, required the cryo, successfully treated, still holding very well. This was a recent case. I had a buckle in our department, came in 2 weeks post-op, routine follow-up, but unfortunately the retina was still detached, bullous detachment, and the break supranasally, there was a big break which wasn't supported by the buckle. Injected the SF6, and this injected the SF6 in the morning, and this picture was taken in AFIU in the afternoon. And if you see within few hours, the retina is dry, but still inferiorly. Inferiorly, still the retina, there is still subretinal fluid inferiorly. But this will go away with the RPE pump. But the good thing is the retina is attached all up there. Few myths about the PNR. It doesn't relieve the traction, so is it going to work? Is it going to be successful? Let's look on the other side. The most of the laser which we do in the horseshoe tear, there's usually a vitreoretinal traction on the horseshoe tear. If that laser is holding, so this pneumatic should hold, and it does hold. Second myth, it doesn't work long term. But if we see the pivot study, in the pneumatic group, 1 to 2% had a redetachment, while in the PPV there was 2 to 3% redetachment. The purpose of the talk is to reduce the burden on the clinic and the surgeons. So myth number 3, if you say that the patient has to come in for the injection, then they come in for the laser. And sometimes it's very difficult to do the laser on the second day or third day. And then you have to keep a very close watch on these patients. So is it really improving our clinical flow or reducing the burden? Or is it increasing? So if we look into the pivot study, there's only a 1 day of extra visit in the pneumatic group as compared to the vitrectomy group. Vitrectomy is preferable to pneumatic retinopexy because it's a single procedure, vitrectomy with a success rate. Yes, there is a 12% difference, but that wasn't a significant improvement, a significant number where we can quote that PPV is better than this one. So the summary, it's a quick procedure. I think we should consider. We should apply the findings from the pivot study in our practice. I think it does free up our theater time. It's definitely cost saving. My study or my plan with these patients was just a temporary effect of these patients, or temporary effect of the pneumatics in these patients. But I think we can use this technique as a permanent solution for a detachment. And if we select the cases cleverly, I think, keeping in view the pivot study inclusion criteria, the results are pretty good. Thank you very much.
Thank you, Dr. Amjad. This was a very nice talk indeed. Any questions from the audience before I have a few questions to ask? Dr. Amjad, any preference for a specific gas?
SF6.
Any reasons for your preference?
SF6, मैंने इसमें डाला नहीं है. There are few slides in terms of अगर आपने procedure उस पर discussion करनी है. What do we need? We need something to tamponade. The option is an air bubble. The option is SF6 or C3F8 or C2F6. I think SF6 is the best because we are injecting only a small volume, and within 24 hours, the volume is increasing in the eye. तो वो tamponade एक अच्छा कर देगा. Air को मुझे inject करना पड़ेगा तो it's not going to be 0.3 mils, it's going to be 1 mil. और आँख के अंदर because it's non-expansile. So SF6 is preferable. But on the other side, अगर हम C3F8 को SF6 से compare करें, SF6 is much better in terms of the, मैंने एक केस को C3F8 के साथ किया और उसमें हुआ इस तरह कि the patient developed a detachment later on. जो break था, we treated that break, but patient developed a new one. So long-term tamponade in an eye with the vitreous, I think, can lead to a new breaks.
You're using a different concentration of SF6?
No, 100%. 100% 0.3 SF6.
Okay. So you mentioned, for the sake of our younger colleagues, you mentioned patient selection is very important. So could you just enlighten a little bit on patient selection?
Pivot study के अंदर what they did was, the inclusion criteria was the break has to be above 4 o'clock and 8 o'clock. Secondly, there should be a single break, or if there are multiple breaks, that has to be within 1 clock hours 30 degree के अंदर हो, ताकि tamponade उसका position जो है वो करना आसान हो patient के लिए.
Thank you very much. Any other comments?
Dr. Amjad, can you tell us your experience in our patient, in your patient, like how they come to the follow-up after pneumatic retinopathy, whether they maintain the posture which you have advised, because this is the main problem here. They do not come for the follow-up as you like to see the patient, and they do not maintain the posture. This is what you'd like to
Sir, इसीलिए मैंने आपने slide देखी हो, my failure rate was much higher, and this is one of the reasons. I think going forward, अगर हम इस चीज़ को adopt करें, तो I think we need to admit these patients rather sending them away. First day to second day is a very good time to do the laser. और supervised इनकी positioning करवा दें अपने wards के अंदर probably.
Ideal patient जो है ना वो 10 to 2 तक तो बहुत अच्छा है.
बड़ा अच्छा है. Yes.
लेकिन अगर 10 to 2 से थोड़ा बहुत ऊपर नीचे हो तो मसला करते हैं.
बिल्कुल करते हैं.
हमारे प्रेसिडेंट थे जनरल साहब, क्या नाम इससे पहले जनरल हामिद, ठीक है
जी सर.
डॉक्टर साहब गए हुए थे अमेरिका, उनकी कैटरेक्ट सर्जरी हुई, तीसरे दिन उनकी डिटैचमेंट हो गई. ठीक है, एक आपके इदारे का सरबराह हो और आप हों तो मेरे ख्याल में कि
प्रेशर
ज़्यादा प्रेशर नहीं है कि जी आप विटेक्टमी करके या आरडी सर्जरी करें. तो मैंने चूज़ किया कि न्यूमेटिक रेटिनोपैक्सी करें, किया, और मेरे ख्याल में इट टेक्स अबाउट 6 days कि वो हमने जो गैस बबल डाला था वो आहिस्ता आहिस्ता छोटा होता गया. हम उसको रोज़ाना लेज़र करते रहे और आखिर में हम ऊपर तक, बाद में सर ने आके उसको क्रायो किया, लेकिन हमने स्टेबल रखा उसको. तो ये एक बहुत अच्छा प्रोसीजर है.
Yes. The retinopexy, either with the cryo or the laser, is very challenging. My technique is I usually make the drawings, और मैं blood vessel को draw करता हूँ क्योंकि indirect करते हुए it's difficult to find. And secondly, especially when there is a gas bubble in the eye, so I follow the blood vessels और position करके theater में कोशिश करके जितनी हो सकती है, तो you need to keep the head down ताकि bubble दूसरी side पे जाए और आप laser कर दें.
I think it's a very useful technique, very helpful technique, which you can apply to your patients who are coming with fresh retinal detachment. But there are certain criteria, as the location of the break is very important. Yeah. The size of the break is very important. If the location is beyond 10 or 12, which cannot be maintained, and the patient has to make a special posture for that, that is difficult. The air bubble is not large enough, which can dampen at the break. And secondly, it had to be a single bubble.
Yes.
If you have fisheye formation in the vitreous, that's not going to be as effective. True. So all the tamponades that we saw in your cases, they were very large, very nice single bubble.
एक में था एक छोटा सा साथ पड़ा हुआ है.
But it has to be a single bubble.
True.
If you don't have any gases, because we do it in our outdoor procedure, it's an outpatient procedure. So if you don't have any gases with you in the outpatient, then even air can help. Yeah. You do some paracentesis, make some space, and inject some air bubble. At least that can help the patient to gain some time. And And I think it's a very useful surgical technique which we should all, but selection of patient is very important. If you have cataract which you can't do laser the next day, then it will become a little tricky. But still, patient should be given a chance, especially older patient who cannot go surgery, affordability का problem होता है और कोई इस तरह के issues हैं. I think it's a very good procedure which should be practiced more often.
I think pivot 2 study जो है उसके अंदर inclusion criteria उन्होंने काफ़ी extend किया. Dialysis वगैरह भी उसमें लेके आए हैं. Let's see उसके क्या results आते हैं. Thank you, sir.
Thank you very much. Okay, our next speaker is Professor Tariq Marwat. He will be talking about some innovations in vitreoretinal surgery. He is from Peshawar, professor of vitreoretinal surgery.
Associate professor. Okay, Bismillah ar-Rahman ar-Rahim. I have no disclosures. Vitreoretinal surgery was, the first surgery was being done by David Kessner in 1968 on a primary amyloidosis cases. And it was an open sky vitrectomy. But then in 1970s, early 1970s, Makimer was actually the father of vitrectomy. And he started machine-based vitrectomy, which was later on converted into 3 ports by O'Malley with using the pneumatic cutter. So things were getting improved, and now we are having the era of micro-incision vitrectomy surgery. The smaller gauges are minimally invasive. They have superior safety profile. They have shorter operative time, better post-op patient comfort, less post-op inflammation, and rapid post-op recovery. The wide-angle viewing system has been improved a lot. It has improved the visualization during surgery, and it has ensured safety and efficacy. Although contact lenses are still used in certain centers, but most of the time biome and Recite wide-angle viewing systems are in use. Recite is superior in because of automated focusing, and simultaneously holds both high field and wide field and high mag lenses. The endo illumination system has improved. Conventionally, we have been using halogen and xenon, but nowadays LED light is being used. LED provides enhanced visualization in smaller gauge. Filters reduce the phototoxicity. Sometimes colored lights, they enhance the contrast. Chandelier has facilitated peripheral shaving without assistant. Illuminated scleral indenter are being used by some of the colleagues. Actually, a plastic hood is fitted over an endo illuminator, and it is being used as an indenter. The laser retinopexy has improved a lot. Now we have straight, curved, and illuminated laser probes. With these, now we can laser up to the aura without assistant, and even in phakic eyes without touching the lens. Valve trocar system has evolved, which maintains a closed system and the stable IOP. With this trocar system, there is a less risk of incarcerations, less risk of fish eggs phenomena, and less risk of suprachoroidal bleeds. Cutter design has been improved. With the new cutter designs, there is improved surgical utility. Larger port areas have faster vitreous removal. Port closer to the tip has enhanced stability near mobile retina. Be-well tip cutters has revolutionized the diabetic vitrectomy, and now there is a concept of cutter-only vitrectomy. Be-well tip cutters have actually has enabled the surgeons to work closer to the retina, even in detached retina. The Alcon's ultra-wit and the hyper-wit cutters, they have actually improved the surgical outcomes. The hyper-wit has 2 cuts per duty cycle, and there is much less retinal traction while using these cutters. The cutter speed definitely counts. Higher the cut rates, smaller bites of the vitreous and less turbulence ensures safe maneuver close to the retina, and there is less risk of iatrogenic breaks. The duty cycle is a percentage of the time the port remains open during each cut cycle. It can be adjusted independent of the cut rate. The close bias mode is useful in base shaving, while the open bias mode is useful in core vitrectomy. So now you have independence of wherever you are working, you have much enhanced cutting efficacy. Nowadays, vital dyes are more frequently being used. Conventionally, triamcinolone, fluorescein, ICG, and trypan blue were used for visualization of vitreous and the retinal surface. But now brilliant blue and brilliant blue-green dyes have increased the surgical outcome. Many ergonomic disposable instruments have been introduced, and they have enhanced the surgical outcome. Dual bore side flow cannula has been evolved in valved trocar systems. They eliminate the fish eggs and avoid the jet fluid retinal damage. Silicone soft tip cannula is ideal for fluid aspiration from the surface of the retina and through a tear. The subretinal cannulas 41 and now 48 gauge B-weld microtip are being used for subretinal injections even without vitrectomy and to drain the subretinal PFCL. Finesse loop has improved the outcome in macular surgeries. It facilitates to begin the peeling. The loop tines are designed for no more than 85% penetration into the ILM. So now ILM can be peeled with this instrument with much more safety. And it has actually made the job easy in case of ILM peeling. Newer vitreous substitutes like semi-fluorinated alkanes and semi-fluorinated alkanes with silicone oil by the name of Densiron, they are being used in certain special cases. Some experimental vitreous substitutes, they are very near to come into the market, especially the smart hydrogels. Intraoperative OCT provides better results while peeling. The shadowing of instruments may be an issue in certain cases. Hypersonic vitrectomy is a new introduction which uses ultrasound to liquefy vitreous instead of pneumatic mechanism. The Bosch & Lomb Stellaris Elite is the compatible machine for this type of vitrectomy, and the equivalent cut rate is up to 1.6 million cuts per minute. The heads-up vitrectomy was introduced in the last decade by Claus Eckard, and now Alcon is producing the Ingenuity system. There is a large, ultra-high resolution 3D view of the retina with an amazing clarity while using this system. Less posture problems are being reported. Superior in training fellows is they see the same image as the surgeon does. Surgeon can work with lower light intensity, so less retinal toxicity chance is there. Innovations in the technique include buckling with chandelier. The macular hole surgery Innovations include inverted ILM flap, autologous ILM, lens capsule, amniotic membrane transplantation, autologous retinal free flap, graft, arcuate retinotomy, perifoveal radial incisions, etc. The diabetic TRD surgery include prior anti-VEGF injection, combination gauge vitrectomy, intraoperative IOP control, chandelier, colored light source, vital dyes, and bevel tip cutters. EMR, the electronic medical record system, has been improved a lot, and in operation theater there is always a positive impact on every aspect of the surgery. The new frontiers of the vitreoretinal surgery are for stem cell implantation, gene therapy, chip implantation, robotic vitrectomy, and televitrectomy. To conclude, VR surgery is a dynamic subspecialty heavily dependent on technology. Artificial intelligence and deep learning algorithms are the future. Innovative new tools improve the accuracy, maximize the efficiency, and minimize the waste. Thank you.
Thank you, Dr. Marwat. Any comments? You saw a small video clip using the loop for ILM peel. How much does it cost, and is it reusable?
It is reusable in our cases. Its cost is about 30,000.
So that's not bad.
But it's very useful.
So our next speaker was, thank you very much, Dr. Tariq Marwat. Next speaker was supposed to be Dr. Ahsan Mukhtar. I don't think we have Dr. Ahsan Mukhtar here with us today, unfortunately. And then there's Dr. Asfandyar Khan. He is also not here, unfortunately. And then there is Mir Ali Shah Saab, who is also not here with us, unfortunately. So any concluding remarks by the chair, and then with his permission we can conclude.
Update on the recent advances. To my junior colleagues, I would just mention that things will keep on changing. New things will keep on coming. You have to keep updating your techniques, your skill, but master your basic skills. Master your basic skills, and then you can refine your techniques with these. These are just helping instruments. Vitrectomy was done even with 20 gauge vitrectomy, and very nice cases were done with that. Then 23, then 25, and now 27. The things are changing. They keep on evolving, keep on learning, but you can use these things according to your own need. You can tailor your demands according to your own requirement, your skills. You can do a hybrid type of surgery. Use both. Sometimes you have to use combination of 23 and 20 gauge, sometimes 25 and 23. So don't hesitate to do that. Don't restrict yourself to certain one. Be innovative. Thank you very much.
Thank you very much, sir. With your permission, we conclude this session. Thank you all.